everybody. Dr. Ryan here, board certified specialist physician. Thank you so much for joining me, even as we look at an approach to a physical examination of a patient who has a predominant problem of wasting of the hands. Interesting. If you haven't yet subscribed to my channel, I strongly encourage you to do so. Alrighty, so let's get started. Get my pointer in there. Alright. First up, introduce yourself to the patient, position the patient sitting up and obtain adequate exposure, right? Then look at these hands, right? So you must note for any fasciculations which speaks strongly to either a lower motor neuron lesion, or if this might be motor neuron disease, we have a mixture, right, of upper and lower motor neuron signs. So you have fasciculation, which you have increased tone, right, with diminished power. Pattern of wasting, is it generalized wasting, right? Or is it just the upper limbs, including the deltoids? Then you got to compare the symmetry. Is it uni versus bilateral, thenar versus hypo, thenar interossei? Any burn marks which may indicate it might be a possibility of a syrinx sitting in the cervical cord. Clubbing, nicotine staining speaks strongly to what may be a lung cancer, right, infiltrating the brachial plexus. Then moving up from the hands through to the arms, we're talking about muscle tenderness in the biceps, chest muscle tone. Check for percussion myotonia, especially over the thenar eminence, if indicated, that which may indicate myotonia dystrophica. Fatigability and exercise speaks to a problem at the neuromuscular junction and the two kingpins there, myasthenia gravis and Eden-Lambert syndrome. You want to assess muscle power in all groups, including the opponents and abductor pollicis brevis, reflexes with or without reinforcement, finger flexor sign, Hoffman sign, Tinel sign. Tinel sign, as we know, speaks to carpal tunnel syndrome. Then test for sensory loss. Test all modalities, right? So you got your vibration, your proprioception, your light touch, right, as well as sensation to pain. And establish a pattern. Is this glove distribution speaking to peripheral neuropathy, or is it cape-like speaking to something in the cervical cord like a sphinx, versus dermatomal type, which speaks to a specific spinal cord level affectation, right, especially T1 nerve root, right? Is it thenar or hypothenar? Is it dissociated or so-called cortical, right? Other features to look out for, guys: does the patient have frontal baldness, which would lend itself more to dystropia myotonica? Is there ptosis with or without a Horner's? So, Horner's is ipsilateral ptosis, meiosis, anhidrosis. It speaks mainly to infiltration of the cervical sympathetics on one side, often on the back of a Pancoast tumor or a superior sulcus tumor. Heliotrope rash will speak to dermatomyositis, cataracts, a whole lot of causes for those. Look into the fundus for papilledema. Test the jaw jerk and the bulbar musculature, right? Because these are affected if it's a predominantly proximal process or an upper motor neuron process. Check the gag if it's exaggerated. Is speech nasal or spastic? Look at the tongue movements and for tongue fibrillation. Then in terms of the cervical spine movements, test these. Is the supraclavicular fossa so-called full, which lends itself more to a process which causes thoracic outlet obstruction or superior sulcus syndrome? Is there a bruit? You want to examine the lower limbs, right? Inspection, tone, power, and reflexes. Further examination is detected by diagnostic suspicion. Example, you might want to examine the chest if you're thinking about a T1 lesion on the back of a superior sulcus tumor. Examine the heart if you're thinking myotonic dystrophy, the parietal lobe if necessary. You check for unilateral wasting with cortical sensory loss. Alrighty, so this is just a quick revision of how to think through the dermatomes in the upper limb, right? So essentially, let's just get my pointer in there. So C5 is the upper outer arm, right? C6 is mostly the lateral forearm. C7 is the middle finger, quite the rude sign. C8 is the medial hand. T1 is the medial forearm. And remember that T4, they say, is at the level of the nipple, which is quite variable. T7 is xiphisternum. T10 is umbilical. T12 is the suprapubic or the hypogastric area. Once again, C5 is going to be the lateral arm. C6, I beg your pardon, is going to be the lateral forearm. C7, the middle finger. C8, the medial hand. T1 is the medial forearm. T4, the level of the nipples. T7, the xiphosternum, T10, the umbilicus, T12, hypogastric or suprapubic area. Okay, here we're looking at the so-called Saturday night palsy. Hot, 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 staying live. Not Saturday night fever, Saturday night palsy on the back of radial nerve involvement, right? The typical appearance of left radial nerve palsy with wrist drop. Even with the wrist supported, as in picture B, the patient is still unable to actively extend their fingers and thumb at the metacarpophalangeal joint. So this happens, it's called a Saturday night palsy because often what happens is the people at the bars, the bars have these high backrests, and as they relax here, right, they compress the radial nerve, and that leads to a transient radial nerve palsy and inability to extend at the metacarpophalangeal joints. Right, this is the differential for wasting of the small muscles of the hand, guys. So you can divide it or stratify it into spinal cord lesions, anterior horn cell disease, lower trunk brachial plexus lesion, peripheral nerve lesion, myopathy, and tropic disorders. The spinal cord lesions, syringomyelia, which gives you the cape-like, typically cape-like sensory loss, cervical spondylosis, compression of the C8 segment, tumor or trauma, right? Anterior horn cell disease gives you a mix of upper and lower motor neuron signs. So motor neuron disease, spinal muscular atrophy, root compression, C8 compression. Lower trunk brachial plexus lesion could be thoracic outlet syndromes, often keeps company with Pancoast tumors. Trauma, radiation, infiltration, inflammation. Peripheral nerve issues like median and ulnar nerve lesions, peripheral motor neuropathy, myopathy in the way of dystropia myotonica, where classically the forearms are involved more than the hands, distal myopathy. Tropic disorders like arthropathies from disuse, ischemia including vasculitis and shoulder hand syndrome. Okay, my friends, the book of Exodus, chapter 23, verse 22 declares, "But if you are careful to obey him, following all his instructions, then I will oppose those who oppose you." In fact, in the New Testament, we are admonished to pray for our enemies, pray for those who want to harm you. And if he is hungry, give him some food. If he is thirsty, give him something to drink. And so doing, you are heaping burning coals on his head. Right? Be careful to follow God's commandments, and then God will be on your side always. Amen. Here are my references, everybody. Thanks for joining me. Hope to see you soon on another helpful video in this series. God bless you.